Greetings from IGCP and Emerging News. I'm Dr. K.K. Agarwal. We know that vitamin D deficiency is very common worldwide and it affects persons of all ages from infants to adults. Recent research has shown that the effects of vitamin D are just not limited to bone health. It has extra skeletal effects too. Besides the bone problems of rickets in children and musculoskeletal pain in adults, many other health problems including cardiovascular disease, type 2 diabetes, cancer have been recently linked to insufficiency or deficiency of vitamin D. Prevention and treatment of vitamin D deficiency therefore becomes important not only for bone health but also for extraskeletal health. In this second module on treatment of vitamin D deficiency, we present to you various strategies to treat vitamin D deficiency in both infants and adults. This module has been divided into two parts and in the second part in adults. Enjoy the CMA.
Let's now move in a similar vein to treatment strategies in adults. We have discussed in the earlier module all details about vitamin D deficiency in adults. So we will just talk of how should we treat over here. When you start treating vitamin D, remember Indians, the circulating vitamin D in urban Indians is often to the tune of about 10 nanograms per mil, 11 nanograms per mil. And if you're hoping to optimize their D levels to maybe 25, 30 nanograms per mil, you will need more than 600, 800 units a day. So you actually, even for maintenance in India, require at least 1000 if not 2000 IU of vitamin D. And I think that is important. We're not able to achieve or maintain normal D levels with 400, 500 IU. It's very, very difficult to do that, and we'll show you that. So in this study, Goswami actually looked at D3 supplementation in adults, and he gave 60,000 units weekly for 8 weeks, which is a standard protocol. Fine. So these are vitamin D deficient adults, and their D levels changed and they improved and became normal. And 1 year later, when he followed up the same men or women, he actually found that D levels are back to where they were. See in the lower graph here, they go up and they come down. So this study emphasizes the importance of maintenance dose in vitamin D treatment. So give 60,000 per week for 8 weeks, follow it up by about 2000 IU per day, or maybe 1000 if you want to be extra careful, but 2000 is good. 2000 IU per day continuously, and which means either you're giving a 2000 IU pill per day, or you're giving a 60,000 unit sachet once a month. And that's how we would approach vitamin D deficiency in adults. And look at this 60,000 IU per month data that we generated a few years ago. And that clearly showed that at least during summer and most of the year, just giving one sachet of 60,000 IU per month is able to maintain vitamin D in patients who didn't start off with serious deficiency but were just found incidentally to have low vitamin D levels. And the vitamin D pickup is huge. It jumps. If you're at very low level, there is a marked rise in D level with these doses of vitamin D. So therefore, for the general public, for anyone at risk, without measuring a D level, using 60,000 units per month or 2000 units per day is usually good to maintain the D level in a reasonable range. This is a study where we followed people up for 9 months. Now the other thing in this is that during winter this may not be adequate, and it is possible that during winter to maintain ideal levels you may require more D administration, because in winter the angle of the sun differs, the UV beta rays differ, and you don't make that much vitamin D as you do in summer. So let's look at women, actual postmenopausal women, and we tried giving them 500 units or 1000 units of D per day along with their calcium. And with 500 units per day, which is typical of a calcium pill that contains 250 IU. So you give 2 pills per day, 500 milligram calcium twice, 250 IU vitamin D twice. You were not able to achieve very significant differences in D levels. So if someone is taking calcium, which has some vitamin D, it will not be enough to raise the D levels significantly. So you have to use pills that have higher doses of vitamin D, including some that have 500 units of vitamin D. So if you use them, you can use that twice a day and then you get 1000 units, then you achieve somewhere closer to what your goal is. And you may actually want to use pills that have 1,000 units of vitamin D now. So if you use a calcium pill with 1,000 units of vitamin D, you use 2 pills per day, you will get 1 gram of calcium and you will get 2,000 units of vitamin D, and that would be the most appropriate for most postmenopausal women. What about injectable vitamin D? We just spoke about it, and in this study we compared one shot of 3 lakh, that is half the ampule, 3 lakh shot of vitamin D versus 5 doses given orally of 60,000 each, so equivalent doses, and they had almost equivalent effects. So therefore, a single dose of 3 lakhs units of vitamin D is actually equivalent to giving 5 sachets, and that's what we need to remember. And injectable preparations may stay longer in the blood because of their slow dissolution. So therefore, it's important to remember that when you're using injectable, if at all you're using it, use just one shot at a time. Wait at least 6 months before thinking of repeating a shot, maybe even a year. Check the D levels if you want to repeat a shot again. Otherwise, there's very little indication for using injectable vitamin D. I would strongly recommend that we stick to oral vitamin D tablets, capsules or sachets. Coming towards the end, what does the US Endocrine Society say? And we've shown you a lot of Indian scenarios, Indian data. This table shows very clearly what kind of D recommendations are there. The recommended dietary intake for vitamin D, daily intake, is really variable. But if we look at adults, it is at least 600 IU per day. But look at that. To maintain 25D at normal level, in the right column you will see, you need, even in the US, where the baseline D levels are often 18, 20 nanograms per mil, you need 1500 to 2000 IU per day. So therefore, in Indians, if you're talking of optimum bone health, you do require that. There's also a center column in this, which says that vitamin D could have significant extraskeletal benefits, but it is not clear as to what is the correct dose for that. So I think we should just treat vitamin D as an important parameter for bone health improvement, and automatically we will probably get benefit on a multitude of other disorders, because hard data on vitamin D supplementation and non-skeletal disease outcomes is still not there. There are some studies that show there is definite improvement. For example, a study recently done from Calcutta showed that when you go from pre-diabetes to diabetes, if in a vitamin D replete population which were given vitamin D to make them replete, the conversion from pre-diabetes to diabetes was less. So if you have two groups of pre-diabetics, one is given vitamin D, one is not, the one that is given vitamin D seemed to have, in this small study, less chance of developing frank diabetes. Anyway, there are others that don't show this. So while the correlation between extraskeletal effects like extraskeletal health and low vitamin D is strong, evidence that treating vitamin D will reverse these conditions is still being gathered, developed and analyzed. So we don't have the final answer on that. What is the upper limit of vitamin D dose? As you know, we have a generous safety margin, but if you look at that, look at adults for example, this is a list of all age groups. Till 1 year it's 2000 IU per day, 1 to 3 years 4000 IU per day. This is like the dose that is recommended. Okay, higher doses, so upper limit is not really there, but this is what has been used so far. And if you're looking at adults, it is 10,000 IU per day. So there is some little controversy about the upper limit that is applicable to children, but I think you're pretty safe if you're going up to, even up to 1 year olds, between 6 and 12 months, up to 5,000 IU per day, you're quite safe for a short period for treating those children, not forever. This is for 8 to 12 weeks. When you're giving them long term, these are the kind of doses we talk about. And in adults also, we should not go above 10,000 IU per day. So when you look at actual treatment, as I said, 0 to 1 year, 2000 IU per day or 60,000 IU weekly for 6 weeks, and then maintain them. 1 to 18 years, 2000 IU per day or 60,000 weekly for 6 weeks seems to be a very standard international recommendation, and maintenance phase doses are between 600 to 1000 IU per day. And in adults, use 6000 IU per day or 60,000 IU weekly for 8 weeks, followed by maintenance, as exactly as I was saying. This is the same recommendation as the US Endocrine Society of about 2000 IU per day. Remember, however, those who are obese require higher doses of vitamin D. Those who have absorption issues, they require higher doses of vitamin D. Those who are on medication that I already discussed, anti-epileptics, anti-tubercular medication, they require higher doses. So in one line, for adults, the standard protocol again will be to give 60,000 IU once a week for 8 weeks, followed by maintenance with 2,000 IU per day or equivalent, which is either 2,000 IU given daily or 60,000 IU given once a month. And that should usually suffice for most of your population. You don't necessarily have to go on measuring vitamin D, because almost all Indians are vitamin D deficient. So unless there is a specific bone related issue, for example, in people who come with rickets, osteomalacia, etc., where you may need to document how high the vitamin D is going and how much to correct it, or in cases where you suspect toxicity, in the routine, your normal walk-in common garden variety of patient, you don't have to send them all for D level measurements. That really adds to cost. The testing is much more expensive than the treatment. Secondly, don't use injectable preparations as far as possible. Thirdly, don't use expensive, fancy, activated vitamin D analogs like 1,25-dihydroxy-D3 or 1-alpha compounds for treatment of vitamin D deficiency. Good old calciferol, cholecalciferol, D3 is sufficient for that. And it is much cheaper, it is much safer and very reliable. So there is no need to go for a lot of fancy tests, a lot of fancy medication, just the basics will do. Should we use D2 or D3? In the US, they often use ergocalciferol, that is plant source vitamin D, that is D2. And we use cholecalciferol, which is D3. And in the International Osteoporosis Foundation position statement, of which I was a part, we have recommended D3 more than D2 because D3 has a longer half-life, but otherwise efficacy is similar. And then I've already emphasized active metabolites should not be used unless there are special circumstances. The determination of dose will determine if you're really being fine-tuning your treatment to a person with bone disease, where you have looked at the D levels and everything, the baseline D level, whether there is any vitamin D in the diet or not, is the person obese or not, and what is the concomitant drug therapy that's being used. But in general, a rule of the thumb to remember is that 100 IU of vitamin D will raise the level by 1 nanogram, which means that if you're giving 200 IU daily, you're going to raise the level by 2 nanogram. If you're giving 1000 IU daily, you're going to raise the level by 10 nanograms. If you're giving 2000 IU daily, you might raise the level up to 15-20 nanograms. But there are many differentials in this, including the fact that when you're going from very low levels to normal levels, you get very rapid increments. When you try to go from normal to optimum levels, you actually get somewhat slower speed and higher doses are required. So this is not a linear relationship. However, for clinical practice, good to remember 100 IU extra per day means 1 nanogram per ml rise in vitamin D. There are also non-skeletal functions of vitamin D, which we've already emphasized. We know that vitamin D is important for immunity. Risk for pneumonias and infection is higher in D deficient children. It's important for autoimmune disorders. It is important for diabetes, heart disease, blood pressure, so many other things, even cancer. All these conditions have been linked to low vitamin D status. They seem to be more common in people with low vitamin D, and even more so, people with low vitamin D and these conditions seem to have poorer outcomes. That's why it is important to understand that vitamin D is not just a bone vitamin, it's actually quite important for everything. So we need to be replenishing our populations and our patients with vitamin D in appropriate doses, not in excess, to get maximum benefit. Remember, however, that the non-calcemic benefits of vitamin D are so far limited to correlations, with some studies here and there showing some benefit. We don't have the final answer that what is the dose and what is the level of vitamin D required for non-skeletal benefits. So therefore, I will conclude my talk by saying that vitamin D deficiency is common in India. We should take steps to make sure that our patients and population does not become vitamin D deficient, and particular areas that we need to target are pregnant women, children, growing children where bones are forming, and older populations where osteoporosis is rampant. These are three groups where one needs to be very, very aggressive and careful about vitamin D status. While being aggressive, again, remember, you should never overdose patients. There's a large window of safety, but don't cross that. So do not use mega doses, do not use active metabolites. Simple, good old cholecalciferol in appropriate doses is good enough. When we do that, we are not only going to help the bone health of our children, of our pregnant women, we will also reduce the burden of osteoporotic fractures later in life. Thank you very much.